end-stage kidney disease is something that patients who have irreversible kidney failure. The cause of kidney failure could be anything, but they have irreversible kidney failure. You could have glomerulonephritis, you could have IgA nephropathy, you could have hemolytic uremic syndrome, you can have, AKI, which is not recovered, interstitial nephritis, anything, any cause of kidney disease. But once it reaches a irreversible stage, the permanent damage sets in. Then you have something called end-stage kidney disease, where the GFR falls to less than 15 ml per minute. So in that condition, we offer renal replacement therapy to patients to take care of the functions that are left over by the deceased kidney. Okay. So those options are, one is dialysis. So that could be hemodialysis or peritoneal dialysis. But the third and the most best treatment and the most advanced treatment is kidney transplant. So kidney transplant has the potential of replacing all your functions of the kidney, the endocrine functions, the secretory functions, the excretory functions. Okay. So the acid base, the the homeostasis functions, all of it can be taken care of by placing a donor kidney, which is compatible in the patient who has got end-stage kidney disease. So the kidney transplant happens. So you have, in the picture you see, there are two native kidneys here. It's not necessary you remove your native kidneys, but you can put the transplant kidney where there is space and where there is a obvious vascular structure where you can anastomose the kidney. The kidney might come from a deceased donor, meaning a patient who is brain dead. Their family can come forward to donate the patient's organs. So they can donate kidneys, they can donate liver, intestine, pancreas, many things. And or it can come from a live donor, like one of your relatives can give, a spouse can give, children can give, or parents can give to children, grandparents, all that. So it could either be a deceased donor or from a living donor. From the living donor, we're going to take only one kidney. From the deceased donor, two patients will get one kidney of that deceased patient. So how is kidney transplant even possible? Okay. So so you know that even a virus, we have an immune response against infections or, pollen allergies, everything. The body perceives it as foreign and then starts acting against it. It starts producing cytokines, inflammation happens, fever sets in. So this is how the body reacts to something that is foreign. Okay. So it identifies the antigen as non-self antigen, right? So non-self antigen is recognized by the T cell, which then goes activated and then produces antibodies via B cells. And then you have a host of inflammatory reaction. So now what will happen when you give a foreign kidney? So the donor is not your own identical twin. Only identical twins will have everything similar. Okay. Otherwise, all of us will have genetic differences, we'll have antigen differences in many portions of our genome. Okay, so any organ that is being given, the biggest challenge is how do you make the body accept the new organ which is coming from a genetically completely different individual. So that is the main challenge. So it relies on managing the immune responses to prevent rejection. So we call something when the body will reject it, when the body will push the kidney, trying to push the new kidney out of the system by mounting an inflammatory reaction. So that's called rejection. So all of transplant science is about how you manage this immune response. Okay. So cells, tissues, or organs which are transplanted between genetically indistinguishable individuals, it's like, identical twins. Okay. They are not rejected. So they'll not get rejected because everything is the same. The slightest genetic difference between the donor and recipient is enough. So even if your parent is going to give you the kidney, your mother or your father will be a 50% match at least, right? So you can share even more genes, like your mother and father can share genes themselves, and you can have more than 50% even coming from your, match between your mother and you, or from your father and you. But still, there's still a lot of non-matched genes. So even the slightest degree is enough to cause graft rejection. Okay. And in all of these rejection, innate and adaptive, both the immune systems, both the innate immunity, like your natural killer cells, your macrophages and all that, and your adaptive immune system, like your T cell, B cell responses, everything plays crucial role in this allograft survival. And in this, the antigen presentation, as in all infections and all inflammatory response, the antigen presentation is going to be the first step. So the donor antigen will be presented to the T cell. So that antigen presentation is the first step in initiating the immune response. Okay. So why do we have to know all this? Only then you can attack those particular mechanisms by using immunosuppressive therapies and avoid rejection. So you have to know about what are certain terms for understanding it. Allo response. Allo response means response to transplant between two genetically different individuals but of the same species. So between human beings. So we are human beings. We are the same species. So between human beings, but it's between two genetically different human beings. Okay. So that is called an allo response. What is a xeno response? So it comes from, say, you transplant an organ from a pig into a monkey. It comes from a different species into a different species. So that's called xenotransplant. So that's called a xeno response. All right. So allo response is between the individuals of the same species, but those individuals are genetically different. The response to a non-self antigen. So that is called the allo response. So the phases of immune response, first is recognition of the allograft as a foreign allograft. Okay. So it recognizes, the body recognizes that tissue as this is not my tissue. So that is the first step. The second step is lymphocyte activation. What happens after that? The lymphocytes suddenly recognize, oh, there is such a big foreign organ inside the body. So we have to activate the response and push it away because it's not ours. So that is lymphocyte activation. So the lymphocyte activates and then it produces a series or cascade of events. And finally, the final phase is how you finally cause the rejection. So that is the effector phase of the graft rejection. So why it happens? So although I said we are genetically different, what happens is almost all human beings share almost 99% of the genetic material is the same. We all have, say, genes like, say, we have polycystic kidney disease genes, we have PKD genes, we have all our chromosomes are the same, all the genes are the same, almost all the genes, because they are essential for normal functioning of our body, right? So you have your homeostatic gene, you have your hedgehog sequence, you have everything. Everything is going to be the same. And if you have a mutation in important gene, you have a genetic disease, right? So majority of the 99% of the genome is shared almost the same. But then there is some 1% which causes so much variability in all of us. And an important segment that causes that variability is situated on this chromosome 6. Okay, it is only 0.1% of your genome. It is a very, very small part of your genome. Okay, that is called the HLA, the human MHC gene cluster. Okay, is the histocompatibility, major histocompatibility complex. Okay, so why this particular group of genes are so important? It is because if you're a non-identical if you're an identical twin, then even this part of your genome is the same. Okay. But if you are anybody else, this has so much variability that no two individuals in the world can be an identical match. It is very, very, very difficult to have an identical match in the MHC part if you're not an identical twin. So there is so much variability. So my genes, and I would share only 50% of the genes with my daughter or with my parents, with either of my parents. But again, my parents would have shared it from their parents, and it's a combination of two parents, right? So it has got so much variability in this region. Only 50% of them have been expressed. So not all the MHC genes are even expressed clinically. Only 50% of them are expressed, and that variability and that itself causes so much of variability. And when you transplant an organ, this HLA is what actually makes the grafts reject. Okay, so this is the portion of your genome that is very, very important for transplant because this sets you apart as a genetically different individual. Otherwise, most of the genes we all carry the same codons, we carry the same amino acid sequences. All those important genes have to be present for us to be normally functioning. But your MHC cluster has different functions and it has got so much variability in itself, right? So the MHC molecules has a lot of immune function. It is divided into class 1 and class 2. We talked about the gene here. I'm talking about the protein that are encoded by these genes. So the MHC molecule is the protein. The MHC class 1, if you see, it has an alpha 1 and an alpha 2 chain, and it got an alpha 3 chain. Okay. And then it has got one beta chain, which is the beta 2 microglobulin. So it's got three alpha chains and one beta 2 microglobulin chain. And this um, what happens is, so this is kept in the chromosome 15. Okay. The beta 2 microglobulin gene alone comes from the chromosome 15. The rest of it is all expressed by your MHC gene cluster itself. The class 2 has one alpha chain and it's got one alpha chain which has alpha 1 and alpha 2, and it's got a beta chain which has got beta 1 and beta 2. Both of them have a transmembrane component, transmembrane portion, okay, and where the end part of it is jutting into your cytoplasm. All right. So there is a variation in how much of this peptide groove. So the space between the alpha 1 and the alpha 2 on the class 1 and the alpha 1 and the beta 1 on the class 2 is the place exactly where the foreign antigen will come and attach itself, okay, for the MHC molecule to sample itself, okay. So based on whether it's class 1 or class 2, these are expressed on certain types of cells, okay. Yeah. So before we go into what is the difference between these two things are going to be polymorphic. So these genes are going to be very polymorphic. As I said, it's just so variable. Okay. It is co-dominantly expressed. So we have very few, antigens or genes which are co-dominantly expressed. One is your blood group antigen. So you have A and B. You'll have expression of both A and B, right? Similarly, your HLA molecules on both the arms of your genes, both of them will be expressed. Whatever is being expressed on both of your arms of your chromosome, both of them will be, both the copies will be expressed. Okay. So if we looked at 6 classes, right? And 12 different molecules will be there. Two alleles will be there on each of the 6 genes. Okay. HLA-A, HLA-B, HLA-C, DR, DP, and DQ. All right. So these are the 6 HLA alleles, HLA genes, and each of them will have two alleles. So you'll have 12 different MHC molecules expressed by each individual for these 6 genes. All right. So of these, the HLA-A, B, and DR are more stronger. They elicit a more stronger immune response, and hence these are most important in organ transplant. We do now recognize that others are also important, but traditionally A, B, and DR are the most important. And the degree of HLA matching. So if you're really a good match with your donor, say about 12, may you have 10 out of 12 match. These can happen randomly also, or if it's a close relative or a sibling or something like that, or a parent, you can still have at least 50% match, but then you can have additional matches also. So the more the matching, the better the allograft survival. So the classic genes, so the class 1 MHC genes, these are called the classic genes, and these are expressed on all nucleated cells, and they are more associated with CD8 activation, CD8 T cell activation. Okay. There are other non-classic genes and these things which are expressed in stress conditions or NK cells. So that is not important. But your important for both your MCQs and for your clinical understanding is that class 1 MHC is expressed on all nucleated cells, and it's closely activated, and it activates your actions of your cytotoxic T cells or your CD8 T cells. The class 2 genes are the DR, DP, and DQ. Class 1 is HLA A, B, and C. Okay. So this is DR, DP, and DQ. These are expressed on the antigen presenting cells and B lymphocytes. So the antigen presenting cells traditionally, they are your natural killer cells and your macrophages. Okay. So your class 2 genes is going to be expressed on macrophages, your natural killer cells, and your B lymphocytes. Okay. Sometimes they can be induced on activated T cells. So isolated, when the T cell is not activated, when it's quiescent, it does not act like a antigen presenting cell or an antigen receiving cell. Sometimes on an activated T cell or the endothelial cell, these also can sometimes express class 2 MHC genes. And this activates CD4 helper cells. Okay. So apart from these classical class 1 and class 2 genes, there are other non-classical HLA genes that we are recognizing, one of which is HLA-G. So these are not that important. The MICA, and these are the minor antigens, or the minor MICA and MICB. So these ones are also being recognized in non-HLA rejections. So, or the non-traditional HLA genes, when you have them matched, even then when a patient rejects, we think that some variability in the MIC-A and MIC-B genes can cause a problem, and that could be the reason for the rejection. All right. Then there are another group of antigens called the minor histocompatibility antigens. These are called minor because they are less potent in eliciting an immune response. One such one is the HY antigen in males. So male to female donation. So when all males have X chromosomes, but females do not have Y chromosome. So any material from the Y chromosome is going to be foreign to the female. So when a female receives an organ from a male, traditionally the survival is comparatively poorer than a female donating to a male. Okay. But with the modern immunosuppression, we shouldn't be seeing that difference. But when a male donates to a female, the graft survival is slightly poorer than compared to a female donating to a male. This can also be important in patients who have undergone a pregnancy with the husband as the father, and then he again donates to the mother. What will happen? The mother, via the baby or the placenta, is already exposed to the father's antigens prior to the transplant. So she's already sensitized. So when you place the husband's organ into the wife, sometimes they can have an accelerated immune response and have a rejection. So these are the things that we need to understand, how you get exposed to antigens prior to transplant. Pre-sensitization events can happen. Likewise, when you lack the Y antigen at all, when you're female, when you're exposed to the Y antigen, regardless of whichever male gives it to you, then you can have a poor survival. Similarly, ABO antigens, if you see, they are present on all cells, right? So they are also present in your kidneys. So kidneys also express your ABO antigens. So usually kidney transplant is low risk if it's done along the blood group compatibility. So if you're an O group, you can only receive your kidney transplant from an O group individual. The RH antigens are not expressed. Okay, the RH antigens are not expressed on your kidney. Only your blood group antigens, the ABO groups, are only expressed on your kidneys. So positive or negative doesn't matter, but you have to match across your blood group patterns. So if you're O, you can give to anybody, but you can't take it from A and B groups. You can only receive kidney from an O group. If you're AB, you cannot give to anybody, but you can receive it from any blood group, say it O or A or B group individuals can donate to an AB. So it works similar to how your blood transfusion works. Yeah. So other factors, so minor histocompatibility antigens, we came to realize that only because as if you only see the major histocompatibility antigen match, even HLA matched siblings, they are not non-identical, but HLA matched siblings also require immunosuppression. So apart from these 12 genes, 12 molecules, there are other molecules also which can be variable, and that's how the MHC minor histocompatibility antigens got identified. Ischemia reperfusion. So what happens when you give an organ? So you are going to take the organ away from the donor, then keep it in ice, preserve it for some time. Okay, you cannot just go take it and directly put it. So it has to be prepared. There is some ischemia time. So the organ becomes ischemic during the process of anastomosing into the new recipient. So there is a considerable duration of ischemia that is there. And when the ischemic organ is again reperfused, is again kept in the recipient and the clamps are open and the blood from the recipient gushes into the donor kidney, what happens is a lot of ischemia reperfusion injury. There's a lot of free oxygen radicals and lactate overload and everything. So all of these can happen. And also there are lots of leukocyte recruitment. So we think only these factors are important, but there are a lot of adhesion molecules, everything that can take part in the inflammatory cycle and also cause rejection. So again, coming back to the phases of the immune response, the first is the recognition of the allograft lymphocytes. So the recognition, the MHC molecules play a huge part. So when there is variation in your HLA, your antigen, your organ is considered to be foreign and your allograft is recognized as foreign. Then comes the phase of lymphocyte activation and then effector phase. So the antigen presenting pathway is either the direct or the indirect pathway. Okay. So the donor antigen, so the direct presenting pathway is the donor kidney has its own antigen presenting cells, the macrophages and the natural killer cells. So they can present their own antigens. From the donor kidney, it will present its own antigen to the patient's or the recipient's T cell. Okay, so it's very quick. The antigen is sampled by its own APC from the donor kidney and then it's given to the recipient T cells. So acute rejection happens very faster. The indirect pathway is the donor antigen is there, but the recipient's APC has to come, take the antigen, go and give it to the recipient's T cell. So that is an indirect pathway. So that can cause chronic rejection. But whichever pathway the antigen is recognized, this is what finally happens. So this is the antigen presenting cells. So on which the MHC molecules are there. So if you have a, say, class 2 MHC molecule is present on antigen presenting cells and B lymphocytes. So you have your class 2 MHC, which is expressed on this antigen presenting cell. So this will have the MHC2 and this goes and has, if you see on the tip of the MHC molecule, you have the antigen. So this comes from the donor. So this antigen is the donor's antigen from the donor kidney. So that is being sampled and presented to, so this is the T cell. Okay. So this huge amoeba-like structure is your T cell. And this is your T cell receptor, the CD3 or your T cell receptor. So this is being given to the T cell receptor. So the antigen is being presented by the MHC molecule to the T cell. So the T cell is the first line of activation. So once the T cell receives a foreign antigen, okay, if it is a foreign antigen, then there is a lot of co-stimulation. The signal 2 happens. Signal 1 is antigen presentation and it recognizes it as foreign. Once it recognizes, there can be a co-stimulation. Okay, when there is co-stimulation, CD80 and CD28. So this is the ligand and this is the receptor. So when this is there, there is also the CD40, CD154. So all of these are co-stimulatory molecules. So these ones will come and activate the signal 2. All right. And then what happens? These two signals together will make the calcineurin pathway. It will ask the mRNA, it will activate the mRNA by the NF-κB kappa B pathway. And then there will be lot of interleukins being produced by your T cell, of which the most important interleukin of the T cell is your interleukin 2. Okay, the IL-2 or the CD25. So that is CD25 is the receptor for the interleukin 2. So the interleukin 2 is one of the important T cell cytokine, which is produced only when it's activated. So it is activated when there is a foreign antigen and there is a co-stimulatory response. Then the T cell in the nucleus gets activated, produces interleukin 2, and that interleukin 2 receptor is also present only on the T cell. So this via the CD25, it gets activated and then it goes and activates the cell cycle and then T cell proliferation happens. It also produces lot of cytokines which will go and activate the B cell also against this antigen. So against this antigen, the B cell will start producing lot of antibodies. So in the T cell, there are 3 signals. Okay. Signal 1 is antigen presentation. Signal 2 is a co-stimulation. Signal 3 is a T cell activation itself. Okay. So the immune response has to be attacked at all 3 levels to avoid a rejection. So to avoid a rejection, where all we can intervene. So if you want to intervene at the T cell receptor itself, so we can't do anything about the antigen presentation. The donor antigen is already there. So the signal one, you have to use some anti-CD3 monoclonal antibodies. So they can be anti-thymocyte globulin and all these ATG, all that can act at your T cell presentation level itself. Then you have the calcineurin pathway, which can be attacked by your calcineurin, cyclosporin, and tacrolimus, which will go and inhibit the calcineurin pathway. The second one is a co-stimulation. You can either have a CTLA4 immunoglobulin or a anti-CD4 monoclonal antibody. You can also have antibodies against the CD25 so that the interleukin-based T cell activation doesn't happen. All right. And then the cell cycle, which happens which will make the T cell proliferate. Many of the sirolimus, everolimus, then all your anti-proliferators, azathioprine, mycophenolate mofetil, all these drugs act at the cell cycle level. So these are called anti-proliferatives, okay, whichever acts on the cell cycle. So these group of drugs will all cause suppression of all these three signals, okay.